Hello students, in this video we will continue with the sphenoid bone part 3. So in today's session I will tell you about the surfaces which we left in my second part, and here we will discuss about the greater wing of the sphenoid bone. There is one more session of the part 4 of the sphenoid bone in which we will finish this bone. So let's discuss the first posterior surface of the bone. Now dear students, when you will see the posterior surface of the sphenoid bone, this surface faces towards the occipital bone. So here you can see that this is your foramen magnum. Clear? Now when you will see the foramen magnum, you can see that it is a big foramen into the occipital bone. Now this is your anterior end of the occipital bone, which is known as basi occiput, and it is making a joint with this posterior surface of the body of sphenoid bone. Now this joint is a very important joint because it is having a primary cartilaginous joint. It is having a hyaline cartilage which is temporary in nature. So this joint allows the horizontal growth of this skull base. So this is the important question to understand, that which joint is responsible for the anteroposterior growth of the base of his skull. Answer is this joint, which is known as basi occiput and body of sphenoid joint. Now this joint is primary cartilaginous. It is having the hyaline cartilage, and this joint convert into the bone by the age of 20 to 25 years, and it is responsible for anteroposterior growth of the skull. So these are the few important questions for your base of skull. Now the next is your lateral surface. Now when you will see the lateral surface of the sphenoid, you will have that inside the cranial cavity the body is marked by the carotid grooves. Now these grooves are going to accommodate the curvature of your internal carotid artery, which are known as carotid siphons. So when you will see the body from inner side, that means through the cranial cavity, you are going to see the sulcus on both the side of pituitary fossa, and these sulcus are present in this area. So this is the pituitary fossa in the midline, and on the side of the body you will find this F-shaped area which is known as carotid sulcus or carotid groove. Now in this you can see that this is the turn of the internal carotid, and you have to keep this thing in mind that internal carotid is covered by the sympathetic plexus, which is known as carotid plexus. So here when you will talk about the lateral part of the body, it is lined by, or it is having the carotid grooves, and these grooves are to accommodate the internal carotid artery which is surrounded by sympathetic plexus. Now the one more important thing is that this area is also related with the cavernous sinus. So here you will have the cavernous sinus on both the side of the body. It is a paired sinus, so this paired sinus is present here. So this is the area which is known as lateral surface of the body of sphenoid bone. So what is the feature of the lateral surface? The important feature is carotid sulcus or groove. And what is the importance of the posterior area? Now here you will have a joint with the posterior margin of the sphenoid with the basi occiput. Clear? Now we will move to the greater wing of the sphenoid. Now when you will see the greater wing, you know that there are two greater wing. One is going to the right, one is going to the left, and every greater wing is having the three surfaces. One is cerebral surface, lateral surface, and orbital surface. So we will see all these three surfaces, their important features, bony landmarks and structure, those are related to these all three surfaces of greater wing. So let's see first the cerebral surface of greater wing. Now whenever we are talking about cerebral surface, but obviously we are going to see the surface which is coming in contact with the cerebral cortex, that means I am talking about the inside of cranial cavity, not outer side. Clear? Because the name itself suggests that when we are using the word cerebral, this means this surface comes in contact with the cerebral cortex. That means it is an inner surface, not the outer surface. Now, this is a concave surface, but obviously because inside you will have the concavity. Now, this concave surface is going to the part of middle cranial fossa. So, this is the important thing, that when we are talking about the floor of the cranial cavity, it is divided into the anterior, middle and posterior cranial fossa, and in the middle cranial fossa you will find the inner side of greater wing, which is known as floor. Now, it is related with the which part of the cerebral cortex? Answer is temporal lobe. Now, here you can see that this is the inner side of the sphenoid bone. This is the body where you can see the pituitary fossa, and this is your greater wing. This is your lesser wing. So, in this greater wing, here you will have the temporal lobe, which is forming the floor of middle cranial fossa. Now, this area is having the 3 constant foramina. How many? 3. Now, these 3 are foramen rotundum, ovale and spinosum. Now, when you will see this surface, you will find the sequence of these 3 foramina, which you can remember by the mnemonic ROS, rose. Now, this is the foramen which is known as foramen rotundum, and this foramen is antero-posterior foramen. It is not vertical foramen. So, that is why you are not able to see any obvious opening which is going downward, but this opening, if you pass the wire, will go anteriorly, not downward. But behind that you will have these 2 foramina which are vertical foramina, and you can see both openings into the norma basalis. So, but from inner side, if you will see, you will have this foramen. So, sometimes examiner asks you that name 1 or 2 foramina of the skull, those are having their opening in the cranial cavity, but not outside the cranial cavity. Outside the cranial cavity is in term of base. I am talking about that the foramen which does not have the opening into the base of skull. So, one of the foramen is foramen rotundum, which opens anteriorly into the pterygopalatine fossa, but not into the base. In the same way, sometimes you can ask about the internal acoustic meatus, which is also the same, where you will have the internal opening, but you are not able to see the opening in the base. So, this is the one thing. Then you will have foramen ovale and spinosum. Now, apart from these 3, you will have the 2 more foramina. One is known as emissary sphenoidal foramina, which is known as foramina vesali, and canaliculus innominatus. Now, these 2 foramina are not constant finding, but these upper 3 are constant finding. So, let us see all these 5 one by one. First is foramen rotundum. Now, you know that foramen rotundum is going to open into the pterygopalatine fossa. It is the antero-posterior foramen, and it allows passage to the maxillary nerve. So, this is a question of your exam. Now, foramen ovale is again important, which is just posterolateral to this foramen rotundum, and there are 4 structures, those are transmitting. One is known as mandibular nerve. But dear students, here you have to understand that this is your trigeminal ganglia. This trigeminal ganglia is giving the mandibular nerve. Then there is a 2 more divisions, ophthalmic, maxillary and mandibular. Now, this mandibular will come out from the foramen ovale. But dear student, the one important thing which you have to understand, that below the trigeminal ganglia, there is a separate exit of the motor root of trigeminal nerve. Now, this motor root of trigeminal nerve also come out from the foramen ovale. So, what is that? It is motor root. And then both of them will join, and this is going to form a single trunk of your mandibular nerve. So, mandibular nerve is having 2 parts which are related with the foramen ovale. One is mandibular sympathetic, mandibular sensory, and its separate motor root. Clear? Then you will have the next thing is accessory meningeal artery, which is a branch of maxillary artery. Then you will have lesser petrosal nerve, which is taking the fibers which are known as preganglionic parasympathetic fibers, and emissary veins. Now, these emissary veins are going deep into the cavernous sinus and coming from the pterygoid venous plexus. So, if you will see these things here in this video clip, what you are able to understand, that this is the trigeminal ganglia. Now, here these are the 3 branch. This is your ophthalmic, this is maxillary which is going into the foramen rotundum, and this is mandibular which is going here into the foramen ovale. Now when you will see the remaining part of this video, what you are able to understand that how the motor root will come out. So motor root is separate from your sensory. This is the important thing. Now here you can see these are the two separate nerves. Now this thicker one is the trigeminal nerve which is having the ganglia. Ganglia is giving the three branches: ophthalmic division, maxillary division which is going into the foramen rotundum, and this is the mandibular division. Clear? Now this is your bone is known as sphenoid bone. In sphenoid bone, if you will zoom this, what you are able to understand that here there is a separate motor root. Now this motor root contributes into the mandibular only, not into the ophthalmic and maxillary. So ophthalmic and maxillary are pure sensory division, and this mandibular then later on join with this motor root after they come out from this foramen ovale. Clear? So this is the important thing which you always keep in mind, that sometimes you have this question that how many nerves which are related to the foramen ovale. So there are three. One is lesser petrosal nerve, and apart from that these are the two. One is the motor root, and this is the sensory part of the trigeminal which is known as mandibular. Clear? Now we will move to the lesser petrosal nerve. Now if you will see the lesser petrosal nerve, this is the bone is known as temporal bone, and this is your middle cranial fossa, and into the temporal bone there is a hiatus is known as hiatus for lesser petrosal nerve. So this lesser petrosal nerve is visible after it piercing the roof of the temporal bone, enters into the floor, and then it is going towards the foramen ovale. So these are the three nerves which you can see related with the foramen ovale. One is these two divisions, one is motor root and one is sensory root, and this is lesser petrosal nerve. Now this lesser petrosal nerve, from where it comes into the cranial cavity, answer is it is puncturing this temporal bone. It appears here by puncturing the bone, because below that you will have the middle ear. Inside the middle ear you will have the plexus is known as tympanic plexus. From the tympanic plexus this nerve will arise, puncture this bony plate, appear here at this point, then it run in a groove is known as hiatus for lesser petrosal nerve, and then it will come out from the foramen ovale. Clear? Now foramen spinosum. Now as the word suggests that it is a foramen which is present near the spine. Now what is this spine? This is known as spine of sphenoid. So just near the spine of sphenoid you will have foramen spinosum, and this foramen spinosum allow the middle meningeal artery and nervus spinosus. Now middle meningeal artery is again a branch of maxillary nerve, and nervus spinosus is a branch of trunk of mandibular nerve. It is a sensory branch which enters inside the cranial cavity and it supplies the meninges. So here you have to understand that this is your foramen ovale, and from the foramen ovale what will happen? This mandibular nerve is coming out. This is the trunk of mandibular, and then it will divide into the two divisions. And this is the foramen spinosum behind the ovale. Now what is happening here, that this trunk is giving the nervus spinosus which will re-enter inside the cranial cavity. The nerve is coming out, it is giving a branch outside, and then again the nerve will enter inside the cranial cavity. So this is known as nervus spinosus, which is arises and re-enter inside the cranial cavity to supply the meninges, which you can see here in this diagram, that this is foramen ovale, and on both the side you can see that there is a exit of the mandibular nerve. Now after that this mandibular nerve is giving this small branch, and this branch is entering through this foramen, which is foramen spinosum. Now here you can see this branch is going again inside, and that is your nervus spinosus. So this nervus spinosus is a branch arises from the mandibular nerve and entering deep inside again into the cranial cavity, and here it will supply the meninges. Now there are two foramens which may present, may not be present. One is known as emissary sphenoidal foramina. Now this name itself suggests that if this foramina is present, it will allow the passage for emissary vein, and there is a canalicus innominatus. Now this canalicus innominatus allow passage to lesser petrosal nerve, but there is only one lesser petrosal nerve. Then how it is possible that there are two foramen which allow passage? So what will happen? You have to understand that this is foramen ovale, this is foramen spinosum. Now in between them you will have this small bony bar. Now on this bony bar sometimes you will have the foramen which is known as canalicus innominatus. So in such cases the lesser petrosal nerve will pass through this, not from the foramen ovale. So if the canalicus innominatus is present, then it is the area for lesser petrosal nerve. In such cases you have only the 3 structure here, not 4. What are the 4 which I told you? MALE. What is this means? It is mandibular nerve, accessory meningeal artery, lesser petrosal nerve and emissary vein. But when you will have the canalicus innominatus, then this L will go here and remaining 3, mandibular nerve, artery and vein, these will remain here into the foramen ovale. Clear? Now we will move to the next part, that is the lateral surface of greater wing. Now this lateral surface is now outer surface. Now this is the lateral surface which you are seeing here. So this is the outer surface of the greater wing. Now when you will see this surface, it is a L-shaped surface. Now here you can see that this is the surface which is having the L-shaped area. Now this surface is having the area in the norma lateralis also, and when you will see the base, you will find in the norma basalis also. Now this surface is, because it is a L shape, so at this point you will have a very prominent bony ridge. Now this prominent bony ridge is known as infratemporal crest. It is not known as sphenoidal crest. Sphenoidal crest I told you in the last class, which is a feature on the anterior surface of the body. It is infratemporal crest. So this infratemporal crest divides this L-shaped area into the 2 parts, one is this and one is this. Now this temporal surface, this horizontal part of the lateral surface is known as temporal surface, and this will become the part of temporal fossa, and here you will have the origin of muscle is known as temporalis. Then you will have the area which is smaller and horizontal part, and this area is known as infratemporal surface, and it forms the roof of infratemporal fossa. Now dear students, this area is important because this area gives rise to the origin of a important muscle is known as lateral pterygoid. Lateral pterygoid is having 2 heads, upper and lower head. So upper head arises from this infratemporal crest and adjacent infratemporal surface of the greater wing of sphenoid. So greater wing of sphenoid is this. It is having the upper vertical and lower horizontal surface, and these surfaces are divided by a ridge is known as infratemporal crest. This area comes in the temporal fossa, this area comes in the infratemporal fossa. Here you will have the muscle temporalis, and here you will have muscle is lateral pterygoid. So here in this video clip you can appreciate this is the mandible. So we have to remove the mandible if you want to see the clear images of infratemporal fossa. So after removal that you can see the lateral pterygoid muscle. This muscle is having upper and lower head. Now this is the crest which is known as, this crest is known as infratemporal crest. So this area is become the infratemporal surface. Here you can see the origin of upper head. This is the lower head which is arising from the lateral surface of lateral pterygoid plate. Both the head will join to form the common tendon which will insert into the pterygoid fovea. So this is the important surface which is infratemporal surface. Now we will move to the orbital surface. Now dear students, you have to understand this thing that this is your bony orbit. Now when you will see the formation of bony orbit, you should understand that this is the lateral wall of bony orbit, this is the medial wall of the bony orbit, this is the roof and floor of the bony orbit. Now we are talking about the greater wings. Now you will know that greater wings are the lateral projections. So when we will come here, with the greater wings, you will realize that greater wings are contributing into the lateral wall of your orbit. So when you will see the orbit, they are always present along the lateral wall. Now where in the lateral wall? You will find the posteriorly in the lateral wall. Clear? Now this is a quadrangular or quadrilateral in shape. So when you are talking about a quadrangular, you will have the four borders. So here is the upper border. So where is the upper border? This is the upper border. Then you will have the lateral border. This is the lateral border. Then you will have the inferior border. This is the inferior border. And you will have the medial border. So this is the medial border. Clear? So how many borders? There are four borders of this plate. Now the upper border. Now this upper border is going to make a joint with the frontal bone. With the frontal bone. Now which part of the frontal bone? Orbital plate. Which part? Orbital plate. So frontal bone will come from anterior side, will go and articulate like this. So this is the orbital plate which will make a joint here. Then you will have the lateral border. Now here you will have the articulation with the zygomatic bone, and these two borders are non-articular. Now the inferior border is free and the medial border is also free. So we will discuss the all four borders one by one. So let's see first in this video clip how the borders are present. So this is your sphenoid bone, which are, you can see you are making out this bone from the lateral side. Now when you will enter into the orbit, you will find that this is the medial wall and these are the lateral walls. In the lateral wall, you can see that this is the quadrangular bony plate. Now this is the articulation of the upper border with the orbital plate of frontal bone. So this is the frontal bone which is having a horizontal plate which is making a joint here. Now on the side, this is the zygomatic bone. So anterior part of the lateral wall is formed by the zygomatic bone which is making a joint here along with this anterior border. Now you will have the medial border which is free, and this is the inferior border which is free. So dear students, when you will see the bony orbit, you have to understand that this is your upper margin and this is your lateral margin. Now these two margins are making joint with the zygomatic bone and the orbital plate of frontal bone. Remaining two borders are non-articular. Clear? So when we will talk about non-articular borders, there are two terms will come: inferior orbital fissure and superior orbital fissure. Clear? Now these two are the area which are present along the non-articular borders. So superior and inferior orbital fissure, how they are formed? So inferior smooth border form the posterolateral boundary of inferior orbital fissure. So when you will see the inferior border, now along the inferior border, you will have the inferior orbital fissure, and through this fissure, your orbit is communicating with the infratemporal fossa. Then when you will see the medial border, now this is the medial border, and between the lesser wing and this medial border of greater wing, you will have a space is known as superior orbital fissure. So one is superior orbital fissure, one is inferior orbital fissure, which are both bound by the inferior and medial borders of the orbital surface of greater wing of sphenoid. Now dear students, on this medial border, when you will see the medial border, when you will draw it very carefully, you will find there is a small projection is visible. Now you can see this projection on both the side of the medial border. Now this projection is for the common tendinous ring. Now what is common tendinous ring? Now common tendinous ring is attached like this. Now this common tendinous ring encloses the optic canal which is present here, and this will provide origin to all the four recti. So it encloses the optic canal. Now here you can see this is the video clip which will explain you more clearly that when you will see the orbit and you will enter into the orbit posteriorly near the apex, here you can see that this is the ring. Now this ring is known as common tendinous ring. Now this ring is attached on this tubercle, or you can say this projection. Now this is the medial border, and on the medial border you will find a small projection. Now along with this ring is not only attached to this projection but also enclosing this canal is known as optic canal. So when you will see the placement of the ring, it will like this. Now here you can see this ring, and this ring is attached on this projection along with the enclosing of canal. Clear? And there are 4 rectus: superior rectus, medial rectus, inferior rectus and lateral rectus, which are arising from the tendinous ring. It is also known as ring of Zinn. So, dear students, whenever you are talking about the superior orbital fissure, it is a fissure between the greater and lesser wing, and the greater wing medial border is having a small projection which allow the attachment of your ring, and this ring is not only dividing the superior orbital fissure into the 3 parts, but is also enclosing the optic canal. Clear? Now, we will move to the posterior border of the greater wing of sphenoid. Now, dear students, where is the posterior border? So, for the posterior border, you first make a landmark, and this is your spine of sphenoid. What is that? Spine of sphenoid. Now, from the spine till its body, from the spine to the body, you have to draw a line. This line is corresponding your posterior border. This line is resembling the posterior border. So, posterior border extends from body to the spine of sphenoid, body to the spine of sphenoid. Now, this spine of sphenoid is the important landmark between this squamosal border and inferior border. Clear? Now, this posterior border is again divided into the 2 parts, medial part and lateral part. Now, medial part is non-articular. Medial part is non-articular. So, again here you will divide this into the 2 parts. This is the medial part, this is the lateral part. This medial portion of the border is non-articular. This lateral portion of the border is articular. So, this lateral portion is going to articulate with the petrous part of temporal bone. It is articulate with the petrous part of temporal bone. So, here what will happen? You will have this petrous part of the temporal bone which will come like this. Clear? Now, this area which is non-articular is going to form foramen lacerum. What it form? Foramen lacerum. So, foramen lacerum anteriorly closed, anteriorly bounded by non-articular border of the posterior part of sphenoid. This is your articular area. Now, in this articular area, you will have a groove, and that groove is for the cartilaginous part of auditory tube. So, this is known as sulcus tubi. Please try to understand that along this posterior border, there are 2 parts, non-articular part which is having relation with the foramen lacerum, and lateral articular part is having the groove is known as sulcus tubi. Now, in this foramen lacerum, there is a horizontal canal is out there. Now, there is a horizontal canal, and this canal is having opening here which is known as pterygoid canal. What is that? Pterygoid canal. So, let us see in this video clip all these features. Now, first you have to identify that this is the spine, this is your body. So, this part is known as posterior border. Now, this posterior border divided into the 2 parts. Now, here this is your foramen lacerum. So, this is non-articular, and this is sulcus tubi. So, this is articular area. Clear? So, here you will find the articular part, and here you will find the non-articular part. Clear? So, here you have to keep this thing in mind that posterior border is having 2 very important features along with the greater wing of sphenoid. So, now if you will remove the temporal bone, you can very well appreciate this anterior wall of foramen lacerum where you can see this small opening. Now, this is the opening for the pterygoid canal. So, the opening of pterygoid canal is not visible into the norma basalis. Opening of pterygoid canal is not visible because it is horizontal canal and it is passing through the sphenoid bone, and it is having an opening here into the anterior wall of foramen lacerum. Clear? Now, we will move to the squamosal border. Now, this is the border. Now, here you have seen that what is this border? This is the posterior border. Now, till the spine. Now, if you will trace from spine you will go this border. This border is the border which is going to make a suture with the squamous part of temporal bone. So it is going to articulate with the squamous part of temporal bone, which is a squamous type of suture where you will see the overlapping of the bones. The next point is the spine of sphenoid. Now it is a projection at the junction of posterior border and squamosal border. So if you will see these two borders, at the junction of these two borders, you will find a projection is known as spine of sphenoid. Now this spine is important because it provides attachment to the three important ligaments and two muscles. Three ligaments and two muscles. So what are the name of three ligament? Sphenomandibular ligament. Now when you will see the sphenomandibular ligament, dear students, this ligament is derived from the first pharyngeal arch. It derived from the first pharyngeal arch. Now it attached on this spine of sphenoid, and in the mandible it will go till the lingula of the mandible. Lingula is a feature of inner side of the mandible and it is a small projection over the mandibular foramen. So this is a sphenomandibular ligament. Then there is an anterior ligament of malleus. So this ligament is coming out from middle ear cavity, and because malleus is a bone in the middle ear, and then this ligament will reach up to the spine. Then you will have pterygospinous ligament. Now this pterygospinous ligament is a connection between the spine of sphenoid to the pterygoid process. Clear? Now there are two muscles which are related to this. One is known as tensor veli pallati and second is tensor tympani. Now if you will see the most consistent attachment, some books says only one attachment on the spine. So in this all five, if I have to take only one, then the answer is this. So this is the most constant attachment on the spine which you are able to appreciate. Remaining are attached on the spine, but some books says that these are not exactly on the spine but adjacent to anterior posterior or by the side of the spine. But this spinomandibular is exactly start from the spine. Clear? Now there are two very important structures which are related on the medial and lateral side of the spine. One is known as auriculotemporal nerve. Now this auriculotemporal nerve attached or related on the lateral side. So on the lateral side you will find the auriculotemporal nerve. On the medial side of the spine you will find chorda tympani nerve, and here this chorda tympani along with your auditory tube. Why auditory tube? Because the auditory sulcus, or I told you this sulcus tubi is present here on the medial side of the spine. So what are the relations? Now relations of the spine is important. On the medial side you will have chorda tympani. On the lateral side you will have auriculotemporal nerve. So if the spine of sphenoid get damaged, then it can create the problems related with the supply of chorda tympanic nerve and auriculotemporal nerve. Clear? So dear students, in this session what you are able to understand that whenever we are talking about mainly the greater wing of sphenoid, it is having the three surfaces: inner surface which is towards the cerebral cortex, that is in the cranial cavity. One area is inside the orbit, one area is outside where you will have the contribution on the lateral surface. Now this greater wing of sphenoid is having the three very important foramina: foramen, rotundum, ovale and spinosum. It is related with the two important communication with the orbit: superior orbital fissure and inferior orbital fissure, and it is having a small projection in the inferior side is known as spine of sphenoid. Clear? So this is all about this session. So in the next session we will finish the sphenoid bone and we will see the remaining part of the bone. So this is all for today's session. Thank you.